Oh. Welcome to the Coding Education Series sponsored by eCentral Medical Management. This webinar focuses on explaining G2211, which is the Visit Complexity Code, CMS 2024 Changes to Prolonged Time Criteria, and G0136, the Assessment of Social Determinants of Health Risk. G2211 is an add-on code that is effective with dates of service January 1st, 2024. It may be added to office and clinic visits in the code range 99202 through 99215. It may not be added to any other E&M codes. On this slide, you see the full description of G2211. CMS has given some guidance on the appropriate use of this code by giving examples of conditions that may fall into serious or complex conditions. There are two examples, HIV and sickle cell disease. Overall, this code is properly used by primary care physicians and practitioners who have or expect to have a long-term relationship with the patient. This add-on code is for physicians who have mostly E&M services. It is not a time-based code. When a patient has a serious or complex condition, there are occasions when work related to that condition is done outside of an E&M visit. This could be answering questions that are not otherwise billable, renewing medications, and other unbillable work by the physician between visits. This code includes the intensity of that work as well as practice expense, the work done by staff related to the care of patient. It is the relationship of the practitioner and the patient that is the main consideration. If there is a short-term issue or the patient is an overall healthy individual, this code would not be used. You may bill this code if you are the focal point for all needed services like a primary care practitioner, or you are giving ongoing care for a single serious condition or a complex condition. CMS has given an example of patients who present for an acute condition to a practitioner providing ongoing care. This code may be billed even though a serious or complex condition is not being evaluated or treated at this encounter. The cognitive load of caring for this acute condition while having the responsibility for all the needed services is what this code represents. Per WPS, which is a MAC covering the Western United States, comorbidities are not required to be documented in the note for the acute condition. CMS has published transmittals and MedLearn Matters articles related to G2211. Those transmittal and MLN numbers are listed here. I encourage everyone to download the transmittal and MedLearn Matters article 13473 for additional detail. The first transmittal identified that this code may not be billed if modifier 25 is appended to the E&M visit. It is expected that the time and intensity will be captured in the procedure reimbursement. All Medicare MACs have email lists that you and your staff can sign up for. NGS Medicare generally sends 2 emails a week with training topics, updates to FAQs, and local coverage determinations, and other topics that may be of interest to you. Now, not all insurance carriers will reimburse G2211. Since March 2024, after Medicare gave additional guidance on the use of this code, insurance carriers have started to develop reimbursement policies. AAFP.org, the American Academy of Family Practitioners, has articles related to G2211 on their website. Your specialty association may also have info. As of March 2024, the AAFP posted that Medicare Advantage plans for Aetna, Anthem, Cigna, Humana, and United Healthcare will reimburse G2211. But UHC announced on June 1st that it will no longer cover G2211 in its commercial plans and certain other lines of business, effective September 1, 2024. Humana will reimburse it on commercial plans. So the bottom line is check your insurance reimbursement policies. The AAFP has a matrix with a list of insurers who cover G2211 available to its members only. Medicare has additional information in their internet-only manual for claims processing. This is an example of when not to bill. This would apply specifically to urgent care center practitioners who typically see patients for acute conditions only, but they're not the primary care provider for all the care of that patient. There are no restrictions on which specialties may or may not use this add-on code. Typically, a surgeon who operates on a patient and will not see the patient beyond the postoperative period will not use this code. However, a neurologist seeing a patient for epilepsy or another neurological condition and is providing ongoing care for that disease might use this code, since they will be rendering ongoing care related to that serious or complex condition. However, if a patient with a neurological disease that is well controlled and the patient only comes in once a year just to check in and make sure everything is still all well, might not qualify for reporting this code. This scenario may not be considered treating a serious or a complex condition. These are the examples in the MedLearn article. In the first example, they are again emphasizing the ongoing longitudinal relationship with the patient. This would be typical of a primary care service. Note that comorbidities are not noted in the example. In slide 2, there is a serious or complex condition treated by a specialist who has an ongoing relationship with the patient, but it is related to the care related to HIV. In this example, if that trusting relationship were not in place, the patient might not have been open about missing doses of their meds. The lab report may be skewed based upon this, and other treatment possibly initiated in the absence of this critical information based upon that relationship. So the major question all doctors ask is, what do I have to document? And as of today, there are no documentation requirements. Medicare and commercial insurance carriers all have a database of the claims you have submitted, including the ICD-10 and CPT codes. They will look at the claims history for evidence that the patient has been treated by you on an ongoing basis. They might at some point request one or more notes so that they can assess the medical necessity of the visit and review the assessment and plan. Another question that is asked is, can I bill what else can I bill in addition to G2211? You may bill an E&M, the visit, G2211, and prolonged time when it applies on the same encounter. However, if modifier 25 is involved, G2211 may not be billed. On this slide, where I've shown you the prolonged timetable. Since 2021, when the office visit time criteria was changed through December of 2023, there was a discrepancy between CPT and CMS rules. Each had a different time criteria for when prolonged time started. Now, effective January 1st, 2024, CPT and CMS agree on when prolonged time starts for office services due to the change in time related to those office visit codes. There is no longer a range. Rather, each code has a base threshold. The timetable shown on this slide is in the NGS Medicare E&M FAQs related to prolonged time. This slide shows only the office and hospital codes, as those are the most common locations of service. The online timetable includes the CMS requirement for prolonged time for all locations of care. I appended the CPT codes to the left of the timetable for reference purposes. Medicare still requires the G code to be reported for prolonged services. However, you may be able to program your EMR or your billing software to output the prolonged time CPT or G code as appropriate for the respective insurance carriers. The last item I wanted to bring to your attention is HCPCS G0136, which is one of the new codes under the umbrella of care management services. This is not to identify if a patient has a social determinant of health issue. It is used when you have reason to believe there are unmet SDOH needs that could interfere with your diagnosis and treatment of a condition or illness. It is an assessment of one or more known or suspected SDOH needs. The SDOH risk assessment can be performed in both facility and non-facility settings and can be furnished in conjunction with an outpatient E&M visit, including transitional care management services and hospital discharge visits. It may be administered as needed, but will only be reimbursed once every 6 months. Any standardized evidence-based risk assessment tool to assess the SDOH issue may be used, but whatever instrument you use must assess 4 core SDOH issues, and those are food, housing, transportation, and utilities. Other SDOH issues may also be assessed, but these 4 must be included. One instrument that may be used is the PRAPARE, P-R-A-P-A-R-E, which is the protocol for responding to and assessing patient assets, risks, and experiences, and it's available at prapare.org. The results of the assessment must be documented in the medical record, and as far as the ICD-10 code billed with the services, Z codes would be most appropriate. And this service may be furnished via telehealth. Of note, this assessment does not have to be done on the same day as an E&M visit. It may be billed as Incident 2, meaning the office auxiliary staff under the general supervision of the billing practitioner, Incident 2, their professional services. But the Incident 2 requirements must be met, which means an office site of service. Other sites do not qualify for Incident 2 services. The annual wellness visit service would not apply in this situation and will be further described on the next slide. This is not a one and done. As a result of the assessment, a referral to the appropriate source for assistance related to the SDOH need must be done. Discussion with the patient of why they are being referred as well. You cannot just refer the patient to a third-party organization. There must be clinical integration. Documentation should include the referral, that the patient went to the organization and did or did not receive assistance. If they did receive assistance, are they using it? Has it affected their care in a positive manner? How has it improved their care? You cannot just give the referral to an organization. GO136 is not a screening to see if there is an SDOH need. As you will see on the next screen, you have identified a need. Now you will assess that need and other potential SDOH issues. If you are doing a screening, here are those CPT codes, 96160 and 96161. For those screenings, CMS has recommended Accountable Health Communities, AHC, Health-Related Social Needs, HRSN, as a screening tool. In this example, the patient has described reasons for difficulty accessing care due to a transportation issue or an issue with paying for utilities. Based upon this information, there is an SDOH issue and an assessment of the issue identified, and potential additional issues will be done. This service is also an optional element of the Medical Annual Wellness Visit, or AWV. It is an optional at the discretion of the clinician and patient, and separately payable from the AWV with no Part B coinsurance or deductible when part of the same visit with the same date of service as the annual wellness visit. When performed as part of the AWV, it must be performed by an MD, DO, PA, NP, or CNS, or medical professional working under the direct supervision of a physician. GO136 would be billed with modifier -33 when performed with an annual wellness visit. This is a list of resources used in preparing this presentation. If you have questions related to these topics, additional information is available at the CMS MedLearn articles and transmittals and the FAQ sites that are listed. So I thank you for viewing this presentation. Additional information on this topic can be obtained on the company's website, which you see here, www.ecmmgt.com, and it'll be in the video gallery obtained through the main webpage.